Hi everybody, let's start our discussion of extremity trauma from Billy and Love part 2. Description and classification of the injury. When a trauma occurs to the body, there can be a soft tissue injury, there can be injury to the nerves, vessels, or injury to the bone. It is said that when a fracture occurs, it is a soft tissue injury with coincidental trauma to the bone. So soft tissue injuries are very much important. There are several classifications for soft tissue injuries, like Charney classification for closed injuries, Gastillo and Anderson classification for open injuries. It is very important. Gastillo and Anderson classification is very important. And the Ganga classification for severe open injuries. Out of them, Gastillo and Anderson classification is of paramount importance. First, it is important to determine that whether there is a fracture or not, and if there is a fracture, is it open or closed. So how will you describe an open fracture? What is an open fracture? Open fracture is a fracture where the fracture hematoma communicates to the exterior either in a breach in the epithelium or the skin. What is open fracture? A fracture where the fracture hematoma communicates to the exterior through a breach in the epithelial lining or in the skin. It is open fracture. For example, if there is a pelvic fracture and it communicates to the exterior or external environment through the vagina or rectum, it is also an open fracture, despite the fact that there is no wound on the skin. Another example is a mandibular fracture, which can communicate to the external environment through mucosa of the mouth. Again, there is no wound on the skin, but it is also an open fracture because it is communicating to the exterior through mucosa of the mouth. Rupture, breach in the mucosa of the mouth. If there is a fracture of the tibia and there is also a wound on the skin and the fracture hematoma is communicating to the external environment through that wound, it is also an open fracture of the tibia. When trauma occurs to a specific part of the body, all the structures crossing through that area should be considered and should be suspected for trauma. There can be trauma to the muscles or avulsion of the tendons without a break or breach in the skin. There can be trauma to the neurovascular structures. There can be trauma to the bone. And a compartment syndrome can even occur in the absence of a fracture when there is very severe soft tissue damage. Usually it is thought that compartment syndrome occurs with a fracture, but it can also occur in the absence of a fracture when the soft tissue trauma is very high. Now let's come to the Gastillo and Anderson classification, which is very important. Gastillo and Anderson classification is based on four factors. Number one is energy imparted in the trauma, the amount of energy. Number two, size of the wound. Number three, soft tissue damage. And number four, contamination. And it is divided into three types, type 1, 2, 3. And type 3 has been further divided into A, B and C. So let's discuss. Type 1 is when the energy is very low. Wound is less than 1 centimeter and there is no contamination. It is clean wound and the trauma to the soft tissue is very low. It is type 1. Type 2 is when there is open fracture and the wound is greater than 1 centimeter long. There is extensive soft tissue damage. There is moderate energy and moderate trauma. Moderate contamination. It is type 2. Type 3 is when there is very high energy. When the energy is high. And there is extensive soft tissue damage. And there is high degree of contamination. Due to high energy, the fracture will be multifragmentary and unstable. The size of the wound is not important in type 3. Only the amount of energy is very important. The amount of energy, the contamination and damage to the soft tissue. Size is not important. It is further divided into three types, A, B and C, depending whether there is enough coverage after fracture reduction and stabilization. If we have when we stabilize the fracture and after stabilization of the fracture there is enough skin to cover the wound, it will be type A. When there is not enough skin to cover the wound after fracture stabilization, it will be type B. And when there is an arterial injury, a vascular injury, which needs repair associated with fracture, it is type C. The important thing to note that is requiring repair. For example, if there is an ulnar artery injury associated with open fracture of the ulna, will it be a type 3C? No, because ulnar artery does not need repair. Hand can survive on radial artery alone. Similarly, if there is fracture of the tibia with dorsalis pedis artery injury, will it be type 3C? No, because the foot can survive on posterior tibial alone. So, if there is fracture of the humerus with brachial artery injury, will it be a type 3C? Yes, because hand cannot survive without brachial injury, artery. It needs repair. Similarly, popliteal artery needs repair. So, now let's proceed to the peripheral nerve injuries. When there is trauma, nerve can also get damaged. Sidon has classified the nerve injuries. Sidon. He classified the nerve injuries into 3 types: neuropraxia, axonotmesis, and neurotomesis. The names are self-explanatory. Neuropraxia. Praxia means to perform. Apraxia, not performing. Neuron, not performing. Neuropraxia is a physiological conduction block. Nerves are not performing. But there is no structure abnormality. There is only a physiological conduction block. There is no Wallerian degeneration. When the pressure causing the neuropraxia is removed from the nerve, recovery potential is good. Nerve will recover on its own, but it may take some time from weeks to months. So in neuropraxia, there is no structural deformity, no structural problem. There is only physiological conduction block. In axonotmesis, means there is cut in the, there is damage of the disruption of the axons. Axonotmesis, axons has been damaged, but the nerve sheath is intact. In neurotomesis, the whole nerve has been divided. The whole nerve has been damaged. Axonotmesis, only axons have been damaged, its sheath is intact, and there is no Wallerian degeneration. If there is some Wallerian, there is Wallerian degeneration. Yes, there is Wallerian degeneration, but it recovers on its own. There is good potential for recovery. And at which rate the nerve regrows? Nerve regrowth rate is 1 mm per day. Nerve regrowth rate is 1 mm per day. When the axons have been divided, they will regrow and will regrow at the rate of 1 mm per day, and there is good chance of recovery. When there is neurotomesis, neuron has been divided, the whole nerve has been divided, there is no potential for recovery on its own. Surgical intervention is necessary to restore the continuity of nerve sheath. It is important to restore the continuity of the nerve sheath. So in neuropraxia, there is no structural problem. There is only physiological conduction block. When the pressure is removed, the nerve will heal on its own. In axonotmesis, there is damage to the axon. Axon has been divided, nerve sheath is intact, but there is Wallerian degeneration. And there is also a good potential for recovery, and it will regrow at a rate of 1 mm per day. In neurotomesis, there is complete division of the nerve and nerve sheath and nerve fiber. There will be no chance of recovery without surgical intervention. Now let's come to the bone injury. Bone injury is described on several characteristics. First, the name of the bone, which bone has been injured. Then the region of the bone. Then the pattern of the fracture line. First, the name of the bone, then the region of the bone, like epiphysis, metaphysis, or diaphysis. Then the pattern of the fracture, whether it is transverse, oblique, spiral, segmental, or multifragmentary. These are some patterns of fracture. First is spiral fracture. When there is twisting injury, an S-shaped fractures occur. When there is twisting injury, S-shaped fracture occurs. It is spiral fracture. Oblique fracture is when the long axis of the bone and the fracture line crosses at an angle which is greater than 30 degree. It is called oblique fracture. When the fracture line and long axis of the bone are at an angle that is less than 30 degree, it is transverse fracture. When the energy is high and bone fractures at two places and an intervening segment is created, it is called segmental fracture. The two main ends of the bone are not in direct contact to each other. There is an intervening segment of the bone. It is called segmental fracture. These are some types of displacements. The mnemonic is star. The mnemonic is star. S for shortening, T for translation, A for angulation, and R for rotation. Shortening is when two ends of the fractured bone slide past each other due to the pull of the muscles. It is shortening. When two ends of the bone slide on each other in linear or horizontal way, it is called translation. There is no shortening. When an angle is created between the two ends of the bone, it is angulation. And when one end of the bone rotates onto the other end, it is rotation. Usually, rotation is difficult to pick on normal X-rays. It needs special attention and close inspection to look for rotation on the X-ray. In children and adolescents, the fracture line may be incomplete because of the plastic, less brittle nature of their bones. In kids, in pediatric population, the bones are usually very soft, and when a force is applied to the bone may give way. The bone may bend. If the force is very little, the bone will bend, and when the force will be removed, the bone will come to its original position on its own, and it will be called elastic deformation. And when the force applied is greater than that, the bone will bend, and when this force will be removed, it will not come to its original position on its own, and we will have to manipulate it to bring it to its original position. It will be called plastic deformation. What? Plastic deformation. And when the force is greater than that, then the compression cortex of the bone will buckle, and this will be called as torus fracture. When the applied force is greater than the force that causes plastic deformation, it will cause torus fracture. What happens in torus fracture? The compression cortex buckles. And when the applied force will be greater than that, causing torus fracture, there will be green stick fracture. These are incomplete fractures where the tension cortex fails. Tension cortex fails. And when the applied force will be even greater than that, there will be complete fracture. So what is the order? What is the sequence? First, elastic deformation, then plastic deformation, then torus fracture, then green stick fracture, then complete fracture with the amount of force applied, increasing amount of force that is applied to the bone. This is an spiral fracture, S-shaped fracture. It is spiral fracture, and there is also some rotation and displacement. This is an uninjured bone. This is green stick fracture, in which one cortex has been fractured and one is intact. The tension cortex has failed. It is green stick fracture. It is complete fracture, and it is buckling. We can see bumps. It is buckling. It is torus fracture. Now let's come to the classification of bone fractures. AO has classified the bone fractures. In AO classification, each bone has been given a number, and each area of the bone has also been given a number. For example, for humerus there is number 1, for radius and ulna there is number 2, for femur number 3, for tibia fibula number 4. For proximal metaphysis number 1, for diaphysis number 2, for distal end number 3. Similarly, patterns of fracture has also been numbered in A, B and C. If there is simple fracture, it is A. If there is a wedge fracture, it is B. If there is a complex or segmental fracture, it is C. What is simple fracture? When after reduction, complete contact between the two main fragments, it is simple fracture. It can also be transverse, spiral or oblique. When there is partial contact after reduction, there is partial contact between the two main fragments, it is wedge fracture. There is partial contact between the two main fragments and there is a wedge, it is wedge fracture. When there is no contact between the main two fragments after reduction, it is segmental fracture. So partial, so simple fracture A, wedge fracture B, and complex or segmental fracture C. Similarly, extra-articular fractures have been given number A, attributed A, partial articular fractures has been attributed as B, and complete articular fracture has been attributed as C. What is partial articular fracture? When some part of the joint remains in continuity with the diaphysis. Some part of the joint, this part of the joint is in continuity with the bone, with the diaphysis, it is partial articular. And when there is no contact, there is no contact between the metaphysis and diaphysis, the articular cartilage and the diaphysis, it is complete articular. It is given C. So let's elaborate it with some examples. For example, there is a spiral fracture of the diaphysis of the humerus. How will you write it? For humerus number 1. We know for humerus number 1. For diaphysis number 2. There is a spiral fracture. Spiral is a type of simple fracture. For simple fracture A and for spiral 1. In simple fracture, spiral is A1, oblique is 2 and transverse is 3. If there is a transverse fracture of the diaphysis of the humerus, how will you write? We will write it as for humerus 1, for diaphysis 2, for simple 1 and for transverse 3. Similarly, if there is wedge fracture of the femur, how will you write? For femur 3, for diaphysis 2, for wedge is B. If there is segmental fracture, we will write it, segmental fracture of the femur, we will write it 3, 2, C. C for segmental or complex. So let's move to the growth plate injury classification. Salter and Harris classified the growth plate injuries into 5 types, and Mercer Range added the 6th one. The growth plate injuries occur in the child and adolescent population, and they are very important because they may cause complete growth rest or some partial growth. They may cause complete or partial growth, or they even may cause growth abnormalities. So there is a mnemonic for growth plate injuries: Salter. First, S for straight. When the fracture line passes straight, it is number 1. A for above. When the fracture line passes above into the metaphysis and there is a metaphyseal fragment, it is type 2. When the fracture line passes L for low, below the physis, and there is a epiphyseal fragment, it is type 3. T for through. When the fracture line passes through the physis and there is a metaphyseal as well as epiphyseal fragment, it is type 4. E R for eradication. When the physis gets eradicated, gets crushed, rammed, eradicated, it is type 5, and it is very important to know because it causes growth abnormalities and growth rest. Type 6 was added by Rang, and it is injury to the perichondrial ring, which is a supporting structure to the physis. It also causes growth abnormalities. So let's read. Type 1 is simple fracture line just involving the physis, does not affect growth. Type 2 is fracture line through the physis exiting through the metaphysis, producing a metaphyseal fragment. It seldom affects growth, does not affect growth. Type 3 is low, passes through the epiphysis, intra-articular. It also does not affect growth. Type 4 is through and through, passes through epiphysis as well as metaphysis, and there are epiphyseal as well as metaphyseal fragments, and this causes focal fusion of the physis and may lead to growth abnormalities. Type 5, when the physis is crushed. When the physis is crushed and it causes growth disturbances. And type 6 was added by the Rang, and it is injury to the perichondrial structures, and there are also a high chance of growth abnormalities. Now let's come to the fracture healing. When the fracture has healed, fracture has occurred, by nature it starts healing. There can be a direct bone healing or indirect bone healing. Direct bone healing is also called primary bone healing, and indirect bone healing is called secondary bone healing. So what is primary bone healing? Primary bone healing is when bone forms directly without callus formation. When bones form directly without callus formation, it is direct bone formation. When bones forms indirectly, first the callus is formed, then bone forms, it is called indirect bone healing or secondary bone healing. So when primary bone healing occurs and when secondary bone healing occurs. Primary bone healing occurs, direct bone healing happens when there is cortical opposition and absolute stability. The most important thing is there is rigid stabilization of the fracture. There is absolute stability and there is no gap between the fracture fragments. And the fracture has been fixed in such a way that there is no movement at the fracture site and it is very rigid and stiff fixation. The direct bone formation will occur without the formation of callus. It occurs when the fracture is stabilized with compression plates. But in most cases, indirect and secondary bone formation occurs. First, a callus is formed and then bone healing occurs. It is called secondary bone healing. When there is some micro motion at the fracture site, when the fracture has been stabilized but it is not so rigid and there is micro motion at the fracture site, this will lead to secondary bone healing. First, fracture hematoma is formed which fills the gap, and then fibrous tissue is formed, then callus, and then first soft callus from hematoma, fibrous tissue, then soft callus, and then hard callus, and then mature bone. The blood supply is very important thing for fracture to heal. If there is lack of blood supply or there is some interruption in the blood supply, the fracture may not heal. So there are 3 factors which affect fracture healing. First is biological factors, biological environment like the infection or the blood supply to the fracture ends. Second is our mechanical factors, mechanical environment like stability of the fracture, is there any micro motion or not, and third, there are patient factors like if the patient has diabetes, there may be some interruption of the blood supply and there may be delayed healing. So 3 factors affect bone healing. First, mechanical factor, biological factor, and patient factors. Let's come to the terminology of bone healing after fracture. Union. When we say union has occurred, a fracture that has healed sufficiently. Clinically, we say a fracture has healed when the fracture has healed sufficiently and is able to withstand physiological loads with very little pain and minimal tenderness at the fracture site. We say that fracture has healed. When the fracture has healed sufficiently and is able to withstand physiological loads with very little pain and minimal tenderness, we say fracture has healed. And radiologically, when the bridging callus has formed at the fracture site, when the callus bridges the fracture site, we say union has occurred. How we say clinically? When the fracture is able to withstand physiological loads with very little pain and minimal tenderness at the fracture site, we say fracture has united. Radiologically, when the callus bridges the fracture site, we say fracture has united. Delayed union. When the fracture has failed to unite in the expected time frame. For example, we had expected that fracture will unite in 3 months and fracture has not united in 3 months. We say there is a delayed union. And what is non-union? Non-union is when the fracture has not healed and has no potential to heal without further surgical intervention. When we say there is non-union, when the fracture has not healed and there is no potential to heal without further intervention, we will say there is non-union. But minimum 6 months are required after trauma or after fracture to label a fracture as non-union. Minimum 6 months. Before 6 months, we cannot say there is non-union. We can say there is delayed union, but we cannot say there is non-union. Minimum 6 months are needed to label a fracture as non-union. When the fracture has not healed and there is no potential to heal without further intervention, we say there is non-union. What is consolidation? When normal cortical pattern appears, we say bone has consolidated. And with the forces passing through it, the bone remodels with age. It is called remodeling.